Please start, sir. We are live.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this hepatocellular carcinoma update. Sir, Dr. P.N. Rao, sir, over to you, sir.
Thank you very much. I am Dr. P.N. Rao. I am hepatologist at the AAG Institute of Gastroenterology, Asian Institute of Gastroenterology. I'm now the current president for the INASL, that is Indian Association for the Study for the Liver Diseases. As you can see here that we have a very good program today, and the reason recently there's been a spate of meetings in hepatocellular carcinoma. That is because of two reasons. For a very long time after the sorafenib, for nearly 10 years, after extensive research and also trial of many of the drugs, one drug came, that's the lenvatinib. And also we have at our disposal several other drugs also when the first line drugs fail, like cabozantinib is available there, and immunotherapy is also coming up in a big way. And most of our people also, they come at a somehow or other, they come at a later stage. Although now we are trying to improve this by surveillance. We have now here 4 experts, and let me introduce Dr. Dharmesh Kapoor, who is a senior consultant hepatologist with an extensive experience in liver transplant. He is now currently in the Yashoda Hospital. Dr. Mithun Sharma, and he is a hepatologist at AAG Hospital, and he's been trained in Singapore, and then transplant training he has underwent. And we have Dr. Anand Kulkarni, and young upcoming hepatologist, and he has the first experience, Indian experience of lenvatinib, published recently, and Dr. Bharat Patodia, who is the medical oncologist, and also Dr. Rajesh Ballam also will be there for conducting the panel discussion. And with this, I hand over to Dr. Dharmesh Kapoor for the how, the Indian hepatocellular carcinoma, where do you place this between the West and then the total East? Over to you, Dr. Dharmesh.
Good evening, sir, and good evening, friends and colleagues. Just share my slides.
The green button, then entire screen option.
Can you see the slides?
No, sir, we cannot see your screen. So you have to click on the green button, share screen button, then select your slide. Then select the entire screen option, so that would be better.
Sure, let me try again. Can you see the slides?
Yes. We are able to see the slides, please.
Is it in slideshow mode?
No, not as it. You have to enlarge.
So you have to go likewise we have done in the trial.
Not able to see?
No, we are able to see, but not in full mode, expanded mode.
So I have removed your slides. So you have to reshare. Green button, then select the first box, the entire screen option. And then you load your slides, sir. Okay. The same we have done in the trial, sir.
Can you see the slides?
Yeah, we are able to see. Now,
is it full screen now?
You are doing it correctly, but it's not coming in a full screen. Do you have any animations?
No, sir.
Animation is not there, you can continue with this one. If
sure.
Animations is there, then there is a problem.
Yep. Okay. So
the slides will not change like this. No? So have you mailed this PPT to me, sir?
No. Are you able to see the changing slides? No.
No, sir.
No.
Okay. Then we have to do it again. That's why I told you that we should keep it shared. That was not agreeable to you. Let us do it again because it wastes everybody's time, Share screen.
After clicking on the green button, dialog box appear. Select the First bigger box.
Yes, I have shared that.
Entire
Yeah.
screen option select.
Yeah.
Then you click on the share button.
Okay. Then share button.
Yes. Now perfect, sir. Now it will come.
I hope so.
Yes, sir.
Is it okay?
Good,
Yes,
good.
sir.
Go ahead.
Okay. So I think, as has been said by Professor Rao, there is a renewed interest in hepatocellular cancer in recent times, and that is for a number of reasons. Not that it is a new problem, but we have got now better tools to diagnose this condition. We've all realized over decades that this is one cancer which can present in a very dramatic manner and can kill a patient very quickly. And we all know that hepatocellular cancer, or HCC, accounts for almost 4/5 of all primary liver cancers. And the risk factors have been recognized since a long time, and they are the hepatotropic viruses, mainly hepatitis B, hepatitis C. And then also in recent times, there has been a resurgence in the occurrence of hepatocellular cancer due to NAFLD-NASH cirrhosis and alcohol-related liver disease. Now, even though this cancer might not be the commonest cancer, but when it comes to mortality due to any malignancy, this ranks in the top 3 to 4. And the mortality for HCC has actually been increasing, while for other cancers, it has been declining in the last 1.5 decades. So in some years, this is the second commonest cancer, second only to pancreatic cancer, and at times third commonest cancer causing mortality, third to both pancreatic as well as lung cancer. And it's also very peculiar that worldwide, almost 800,000 cases get reported on an annual basis, and an equal number of patients succumb to this tumor on an annual basis. So this is the figure that you see for the year 2018, wherein about 800,000 deaths were accounted for by HCC. And if you have somebody presenting with advanced stage HCC, then the median survival of these patients is less than 1 year. And during the course of the talk, we would be going through what are the various stages of presentation. But advanced HCC patients have got a very abysmal survival. Now, almost 3/4 of all HCCs, they occur in Asia, and China probably accounts for almost 45 to 50% of these cases. The global prevalence is very variable. In US, it is 16 per 100,000 population, but there are parts of US where again there is a high immigrant Chinese population, where the prevalence might be as high as you see in Asia, which is about 25 to 35 per 100,000. It's a male skewed dominant tumor, and the male to female ratio has been pegged anywhere in various studies from 2.5 to 4:1. What are the common etiologic agents? Again, in our own subcontinent, there is a difference. So in most of the parts of the Eastern Hemisphere, hepatitis B accounts for the bulk of the tumors occurring due to this virus. The HCC is occurring due to this virus. And so is the case in India. But in other countries, especially our neighbor Pakistan, the commonest cause of HCC again is hepatitis C rather than hepatitis B. Similarly, in Japan, there is almost an equal distribution of tumors occurring due to hepatitis B and hepatitis C. And in that way, Japan is a little different from the other countries in the Eastern Hemisphere. It is the 5th commonest cancer in men and the 9th commonest cancer in women. So, and what about the epidemiology of this tumor in our country? Again, we don't have any community-based data or registry data. Please remember that this is not a notifiable disease. And this was a publication from All India Institute about 7 years ago, wherein the authors reported that the incidence amongst men is about 0.7 to 7.5 per 100,000 per year, and in women is 0.2 to 2.2 per 100,000 per year. The mortality rate in men is slightly higher than the mortality rate in women, and it's anywhere from 5 to 7 per 100,000 year. And I've already alluded to the male dominance of this tumor. The age of presentation is between 40 to 70 years, and younger the patients who present with HCC, greater the chance that they would not have cirrhosis as the background liver disease when they present with HCC. And again, in this study, they found that the commonest etiologic agent was hepatitis B virus. So when you are faced with the patient in the clinic, a liver disease patient in the clinic, what do you do? So etiology of the liver disease is extremely important. And therefore, we must remember that the patient sitting in front of us we should not only just know the viral characteristics of that patient, but also what stage of liver disease the patient is in. And this has got some far-reaching consequences when it comes to surveillance strategies. So in the context of hepatitis B, if the patient presents with cirrhosis, the annual incidence is anywhere from 3 to 8%. But if it is an Asian male who is just HBsAg positive, but more than 40 years of age, this incidence could be anywhere from 0.4 to 0.6. If it's an Asian female, the HCC occurrence is more common in the 6th decade, that is beyond 50 years of age, and this is about 0.3 to 0.6%. So this is very important because there are scores online calculators like the REACH-B calculator, which is something that we use very commonly to predict the occurrence of tumor in a given patient. So it's very important that just the mere positivity of HBsAg with advancing age. So this patient needs to be on your radar, and this patient must be subjected to surveillance strategies based on what stage of the liver disease he is in. In various parts of the world, the cirrhosis associated with hepatitis C also carries almost a similar kind of an annual incidence of 3 to 5%. It's also important to remember that when we treat patients with hepatitis C with DAAs, and all of us are extremely gratified by the response rates of these DAAs, which is anywhere to the tune of 92 to 95% SVR, which is sustained virologic response. We must remember that if these patients have been treated at the stage of cirrhosis, these patients must continue to remain under surveillance. So this is a very important message, that just because somebody has become a viremic or just because somebody has achieved an SVR does not mean that we stop short on our surveillance strategies. So much so that the EASL also recommends the surveillance strategies to be in place for F3 fibrosis. And maybe during the panel, we can talk about how to distinguish between F3 and F4, which even in the best of hands at times can be a very uphill task. But suffice it to say that even though the incidence with F3 fibrosis is slightly less than F4 fibrosis or cirrhosis, which is intuitive, but even these patients need to be under constant surveillance. And then some uncommon genetic disorders, not so common in our clinical practice, including hemochromatosis, alpha-1 antitrypsin deficiency, so on and so forth. So it is extremely important to know that cirrhosis from any cause is the most common cause of HCC occurrence. And worldwide, hepatitis B and hepatitis C, and in some parts of sub-Saharan Africa, still the occurrence of HCC, because aflatoxin being the agent which is implicated, is quite common. And in recent years, there has been again a resurgence of the obesity epidemic, and in that context, the NAFLD-NASH related liver disease. And mind you, some of the patients with NAFLD-NASH related liver disease might not even be cirrhotics when they develop the HCC. And then again, alcohol use disorder related liver disease, that is very common cause of HCC, and which is seen now worldwide. Now, in earlier years, it was believed that alcohol-related liver disease is not so common, and there needed to be the hepatotropic viruses on board to cause HCC. So if you were to look at only pure AUD-related etiology, it would be anywhere from 2 to 4%. But if it was a synergy between the hepatotropic viruses and alcohol use disorder, then the occurrence of HCC was more common, again anywhere from 4 to 8%. So we see this recent resurgence of AUD-related HCC, and I think this is again something which should not be taken on face value, and there is something more to this being the etiology rather than just saying that the alcohol use disorder has changed or something else has changed. So I think this is something that needs discussion and cannot be taken on its face value, that suddenly when you have alcohol as the etiology of liver disease, the occurrence of HCC has gone up. Peculiar to our part of the world is also hepatic venous outflow tract obstruction, and it is extremely important that long duration of HVOTOs, especially long segments obstruction or involvement of IVC or involvement of both hepatic veins and IVC, it predisposes to the occurrence of HCC. And this is one group of patients in whom imaging can be very taxing, as we will see in the latter part of this talk. And therefore, it is very important to have a very low threshold for going with the cross-sectional imaging, keeping these patients on follow-up, using the tumor markers, and any modality that you might have at your disposal to be able to diagnose HCC in this setting. Now, quickly changing gears and coming to the diagnosis of HCC. So again, this is one tumor, and this is very contrary to conventional oncologic practice, where you can diagnose a malignancy without any histological proof. So the mainstay of diagnosis of HCC has been imaging over the years, and in more recent times, all of us have got familiar with the terminology called LIRADS. We no longer call space occupying lesion in the liver a lesion. We call it an observation. And then this LIRADS has evolved over a period of time, and in its most recent version of 2018, it has set the framework or the lexicon in which all these observations should be reported, so that the person who's reporting and the person for whom it is being reported, they are on a common page. So this is a common lexicon for the radiologist, for the pathologist, for the clinician, whether it's a hepatologist or a surgeon, so that they all know what is being talked about. Now, these are the various diagnostic categories for the LIRADS. So the first one, as you can see at the top of this slide, is LIRADS non-categorizable. So either the imaging was not of proper quality, or the images are degraded and they cannot be used to report with certainty what the characteristics of this observation are. Then you see the top three rectangles, which are LR1, LR2, LR3. So most of the LR1 and LR2 are definitely or probably benign. That means the radiologist is almost certain that this observation is not a malignant observation, and therefore these patients can be just kept on follow-up. And most of these are like cyst, hemangiomas, and at times benign space occupying lesions of the liver. LR3 has got an intermediate probability of malignancy, and when somebody is diagnosed with LR3, and if there is background liver disease, whether it is chronic hepatitis or cirrhosis, we try to manage these patients by offering them an earlier imaging modality. So rather than imaging them, say, at 6 months for surveillance, you might want to do it sooner, maybe 3 months. And if you find that even the other ancillary investigations like tumor markers are available to you, and they are also not in the normal range, you might want to do it even sooner than that. Then you see these two rectangles and a vertical rectangle, which is LR4 and LR5, denoting probable HCC and a definite HCC. And then on the left-hand side, you see the large vertical rectangle, which is LIRADS malignancy. So this basically means that the imaging is suggestive of a malignant observation, and this need not necessarily be HCC. So that means you cannot categorically say that this patient has got a HCC, but the imaging characteristics are akin to that of imaging of a malignant observation. And lastly, you see in the black an LR tumor in vein. So again, this is very common for HCC, and we all know that this has got prognostic significance. This is a tumor which has got a predilection for the portal vein and the hepatic veins. And if the lesion is contiguous, then you're almost certain, and the portal vein also shows the same kind of imaging features as you see in the lesion in the parenchyma, then you know that what you are seeing in the portal vein is a PVTT, or portal vein tumor thrombus. So most of the description for the space occupying lesions in the liver would be characterized by these categories of LIRADS. So now this is a very important slide, and I think all of us can keep it on our desktops or on our workstations. So please remember that LIRADS does not give you any handle on which investigation to use. So ultrasound is used for surveillance, whereas you have got a LIRADS for the CUS, which is contrast enhanced ultrasound, cross-sectional imaging of with CT or with MR. And please remember, these are all dynamic imaging. That means you have to image the patient in the plain phase without having administered any contrast. Then in the late arterial phase, and that is extremely important, it should be the late arterial phase and not an early arterial phase. Then the patient to be imaged in the portal venous phase and in the delayed phase. And some centers would use a really delayed phase also to enhance the discriminant value of a given observation. Now, the most important hallmark of the HCC observation is that you have an arterial phase hyperenhancement. And this arterial phase hyperenhancement is not towards the periphery of the tumor. So this is a arterial phase hyperenhancement that occurs in the center of the lesion. Now, if you see that any lyrid lesion which is less than 1 centimeter, and all of us oftentimes contest that MR is better than CT and this particular modality is much better than the other. Please see the right side of this table and you can see that in any observation which is less than 10 millimeter in size, it would not qualify for an LR5. So even if you have all the characteristic features, so all this fight about being able to diagnose with conviction lesions of less than 5 centimeters, they actually cannot stand on its feet. So only when you have got a lesion between 10 to 19 millimeters or greater than equal to 2 centimeters, then you can characterize them completely. Now, what are the various things that you have to be able to discern to be able to tell what this lesion is? One is the enhancing capsule, which you are able to see generally in the delayed phase. Then the non-peripheral washout. So the washout occurs pretty much the same way as the arterial enhancement occurs. That means again, it is in the central part of the lesion. And then the threshold growth. That means in about 6 months time, if a given lesion has increased to by 100% of its original size, then you say that it has fulfilled the criteria of threshold growth. Now, if in this table you see that the additional characteristics might be none, 1 or 2, greater than 2. So if a lesion is less than 2 centimeter in size, there is no way you would be able to, if there is no APHE or no arterial phase hyperenhancement, you will not be able to assign an LR5 in any circumstance. So that means this by far is the most important diagnostic characteristic of a HCC. Whereas if you have a non-rim APHE, even if the lesion is 1 to 2 centimeter in size, you can diagnose LR5. So here you can see that it is LR4 if there is an enhancing capsule in the delayed phase, or it is LR5 if there is non-peripheral washout, or there is threshold growth, which are defined as more than 100% in a 6-month period. However, when the lesions are more than 2 centimeters, you can see that probably they are malignant or they are definitely malignant. So the confidence of being able to label an observation which is greater than 2 centimeters in size is much greater. So if we use this table time and again, one gets familiar with the nomenclature and as to what to expect in a given observation. So how does this help us? Does it have any bearing on what we are going to do with the given patient? So like I said, that most of the HCCs are diagnosed just by diagnostic imaging. This is one tumor which we have not biopsied, and this is still something that is the standard of care. However, the lyrid system tells you that if the lesion is LR4, but the background liver disease is such that you don't want to miss an HCC, something which is in the vicinity of a vessel or something like that, then you might want to biopsy this. Similarly, you might have an lyrids M, that means its imaging characteristics are like that of a malignancy, but not necessarily HCC. That is again a situation in which you might want to have a pathological diagnosis. And now very, very rarely you might want to biopsy just to be sure that what you are seeing in the portal vein is a bland thrombus or a PVTT, because this has got special importance in patients who are being worked up as candidates for liver transplant. Of course, there are other ancillary tools like the increase in the tumor markers or PET avidity for these lesions, which are not the subject of this talk, which can come to your rescue, and they will help you to decide whether the tumor in the portal vein or whether the thrombus in the portal vein is a bland thrombus or a tumor thrombus. So you can see in all other categories, you probably don't need any histological diagnosis, but these are the categories. So especially lyrids for most centers, if the lesion is quite strategically located, that means it has a predilection to invade a vessel or a surrounding viscera, you might want to biopsy it and therefore preempt the treatment without reaching the stage of lyrids 5. Now, again, this is a very important graph. So the imaging characteristics are basically aimed at describing an observation to be malignant. Now, this particular diagram tells you that what happens to various observations at various stages of lyrids reportage. So that means if you have an LR1, this lesion has got a 0% chance of malignancy and obviously then 0% chance of having a HCC. If you have a lyrids 2 kind of an imaging, there is about 18% chance, or 1 out of 5% chance only, that this malignancy is going to be a malignant. So this means basically when the imaging is like that of a malignant observation, or the Lyride's reporting system has suggested that this is Lyride's M, and when you have histological proof on these patients, you find that the HCC in this malignant observation would only be 16%. Similarly, for a Lyride's 3 reportage, the malignancy chance 40%, only about a third would be HCC. Lyride's 4, about 4/5 would be HCC. And when it is Lyride's 5, of course, it's a malignant lesion, but almost 9 out of 10 of these lesions, they would be HCC. Whereas if you do not have the kind of APHE, the non-peripheral washout, the capsule and delayed phase and the subthreshold growth that I mentioned, and you are characterizing this lesion as LRM, then there is only a 1/3 chance of this being a HCC. That means some Lyride's M lesions might still turn out to be HCCs. More commonly, these are cholangiocarcinomas or tumors of mixed cellularity. Again, something which has been on the rise in recent years. This is extremely important from management perspective, especially patients who are being worked up or evaluated for transplant, because the recurrence rates are extremely high in intrahepatic cholangiocarcinoma, and therefore this diagnosis must be established with certainty. There are some the ancillary features which come to our aid, and many centers have now started to use this as an abbreviated surveillance tool. So on a semi-annual or an annual basis, they would get only single sequence T2 weighted image for the liver. So no injection of contrast unless you see an observation. Otherwise, you only look for a T2 hyperintense signal observation. If you see one, then you give contrast. Otherwise, this is a good surveillance tool, especially in the context of overweight or obese patients for whom ultrasound surveillance is a challenge. Then restricted diffusion, mosaic character architecture, intralesional fat or intralesional fat sparing, the presence of blood or blood products, and subthreshold growth. So these are the various ancillary features that come to your aid, but please remember the ancillary features can increase the Lyride's grade by 1, but they cannot make you attain a Lyride's 5 status. So that is very, very important to remember, that you cannot go up to Lyride's 5 just with the help of ancillary features. And therein comes the importance of the APHE. So APHE has to be present, and if the lesion is more than 2 centimeters, then this is a no-brainer and the diagnosis is certain.
Sir, sorry to interrupt, sir. 3 minutes to conclude.
Yeah. So this is again a very important feature of Lyrides, which is the response to treatment. So you have subjected a patient to a locoregional therapy, and you want to know whether this therapy has worked. So you image these patients again, and the timing is dependent again on the LRT, and you are able to not demonstrate similar kind of imaging as it was there at baseline. You say it's a non-viable tumor. It might be equivocal, or if you see a similar kind of pattern of enhancement as you saw in the pre-treatment, pre-LRT, you call it LRTR viable, and this patient will need a repeat thing. So quickly to exemplify what I said. So this is the patient, non-contrast CT. You can see that there is a hypodensity in the right lobe of the liver, also extending up to segment 4. This is the arterial phase. So you can see that there is enhancement even of the portal vein. You do not see a margin to this region, but there is intense arterial phase hyperenhancement. Portal venous phase, you can see that the portal vein, right branch of the portal vein is occluded. And this is what you see in the hepatic venous phase. You see almost the entire parenchyma now looks uniform except for the central part of the lesion. And this is a PET scan, which tells you that this is a PET avid lesion. In the interest of time, I'm not talking about this, but maybe this would figure in the discussion. So this patient is subjected to some treatment, and you can see that 4 months later, this lesion has got a lower hypodensity compared to the baseline lesion, less of an enhancement on the arterial phase. Portal vein phase, you now start to see at least some portal flow in the intrahepatic right branch, especially the posterior branch. And this is the delayed, this is the hepatic venous phase. Again, you can see some capsular retraction of this lesion, but otherwise nothing much of note. And this, you can see the portal vein tumor thrombus comparison at the identical levels. And you can see that there is some resolution of the tumor thrombus, especially it is visible in this part of the scan. So there is some restoration of the flow that you see. Of course, you see something here, and this is an observation which you have to make out and characterize over a period of time, whether this is something new or something which is just the effect of the treatment. Another case, again, you can see in the non-contrast, a central, this is a hypodensity segment 2-3. Now, this is very important. Arterial phase, you see a rim enhancement. So you are not seeing a non-rim enhancement. So you can see the center part of the lesion or observation still is hypodense. In the portal venous phase, some more center part has taken up contrast, and in the delayed phase, more part has taken contrast. So what is this? This is a delayed phase, and now you see that only a very little part of the lesion has not taken up contrast. So delayed enhancement of the lesion, the periphery of the lesion matches almost the surrounding parenchyma. So this is again PET avid, and this is obviously a cholangiocarcinoma that we are dealing with. This patient was subjected to a left lateral segment resection, but see what happens to this patient over a period of 3 months. So you again see this hypodensity, but you see some other observations also in the plane scan. Again, you see the no arterial phase hyperenhancement, and this is the portal venous phase. You start to see some uptake in the periphery of the lesion, delayed even more uptake, and therefore this gives you the diagnosis that this was a cholangiocarcinoma. So briefly about tumor markers, and I think again someone else is going to be talking about this. Not all HCCs will have elevated tumor markers, so you can use the AFP or the L3 fraction of AFP and DCP or PIVKA2, which we have been using in recent times. Role of biopsies, we've not biopsied these patients, and I already mentioned that Leydig's 4 lesions or Leydig's M might be biopsied. In earlier years, when PET was not available, we used to biopsy it at times the portal vein also to see whether the thrombus was bland or tumor thrombus. Important is that now you have got actionable mutations in the tumor, and therefore there is a renewed interest in biopsying HCCs. So most of the lesions we should remember, or at least a third of the lesions occur in non-cirrhotic livers, and therefore again the role of biopsies comes in this category of patients. So the practice points, and this is my last slide, the trends in HCC occurrence have been suggesting that there is an increasing number, and this is likely to happen over the next 2 decades too. At least the surveillance strategies for non-cirrhotic HCCs are not in place. And as the therapeutic landscape for management of HCC changes, there is a huge catch-up that is needed for not just imaging, which is reproducible, but also other molecular signatures which the tumor might have, so that we could treat various patients differently depending on the biology of the tumor. Thank you so much for your attention.
Thank you, sir. It's a wonderful presentation. You have covered every point. And now moving to the next talk. The next talk would be by Dr. Mithun Sharma, Director Hepatology and Regenerative Medicine, Consultant Transplant Hepatologist, AIG Hospital. Sir will be speaking on screening and surveillance, why, when, and how.
So is my screen visible?
Yes, sir. Perfect.
Yeah. So my job is cut out because Dr. Dharmesh Kapoor covered quite a significant part of the thing, so that it made my job very easy. So we should all remember that there is a difference between diagnosis and surveillance. So surveillance is when we try to look for some things which have not yet developed, but which we expect to develop, and then it is called surveillance. But suppose we find a round tumor in the liver or a round mass in the liver, and then we try to find out what it is, then we call it as the diagnostic part. The diagnosis of HCC has already been very nicely covered by the previous speaker. So when we talk about surveillance, we should know that surveillance will be helpful only when we know that the disease or the condition is present in a significant number of population. So when we talk about hepatocellular carcinoma, we can divide countries with very high incidence like China and Japan, with moderately high incidence, with intermediate incidence, and in low incidence. The justification of doing a surveillance program decreases as we move from a country of high incidence to a country of very low incidence. What is high incidence? High incidence are countries where it is more than 20 per 100,000 population. If it is between 11 to 20, we call it moderately high. And if it is below 5%, we call it as low incidence. And what falls in between this moderately high and low incidence is called the region of intermediate incidence. So if we talk about Southeast Asia, Asia Pacific, so we see that the commonest etiology, as already has been highlighted by the previous speaker, is hepatitis B and C related, though an increasing number of cases with alcohol-related HCCs have been recently reported. So when do we think that a surveillance is justified? So it is believed that the EASL guideline says that it is effective if it provides an increase in longevity of a life of a person by at least 100 days. Or the US ASLD feels that if the cost per year of life gain is less than 50,000 US dollars, it is considered cost effective. Other way around, any disease, and particularly HCC, which has a more than 1.5% per year incidence, will warrant a surveillance irrespective of the cost. So this brings us to the question, does surveillance program help for patient to detect HCC? So here I bring to the attention two very old studies, one in 2004. It was a population-based randomized controlled trial where they used surveillance ultrasound and alpha-fetoprotein measured every 6 months versus no surveillance. This was a study in Shanghai, close to 19,000 patients with current or prior hepatitis B infection, and these were patients regardless of the presence of cirrhosis. Though the adherence of the surveillance program was only 55%, yet it showed that this surveillance program decreased the mortality due to HCC by 37% in the surveillance arm. So this was a very promising result that brought into picture the role of surveillance in patients with HCC. However, another study from China tried to use only alpha-fetoprotein as a marker of HCC. This did not show any difference in the survival, and this study included only the high-risk male patients. After that, there has been many other small cohort studies which shows that doing a regular ultrasound without even doing an alpha-fetoprotein does have benefits as a surveillance tool. So who undergoes surveillance? So here I have tried to put side by side the EASL guideline, the ASLD guideline, and the APASL guidelines. So cirrhotic patient, Hep B, Hep C, alcohol use disorder, or NASH related, if it is child A and child B, there is a consensus between EASL, ASLD, and APASL that all of them needs surveillance. In child C patient, however, the ASLD and the EASL feels that surveillance is worthwhile only if these patients are awaiting a liver transplant, whereas APASL feels that we can still continue surveillance because we can add life to these patients. In cirrhosis of other etiology, like primary biliary cholangitis or alpha-1 antitrypsin deficiency also, once there is cirrhosis, all the guidelines believe that we should do some surveillance. Coming to the non-cirrhotic patients, now a non-cirrhotic hepatitis B patients, the EASL feels that they are a high risk. We should use the page B criteria. So what is the page B criteria? It takes into account the platelet count. If the platelet count is more than 2 lakhs, it is 0 point. Similarly, if it is between 1,000 or 1 lakh to 1.9 lakhs, it is 1, and if below 1 lakh, it is 2. It takes into consideration the age and gender of the patient. If the total score is more than 18, it is considered as a high risk for development of HCC, which means there is a 17% chance that this patient may develop HCC at 5 years. If it is below 9, it is considered as a low risk for hepatocellular carcinoma. This is for non-cirrhotic patients. The ASLD feels that if it's an Asian male above 40 or an Asian female above 50, or patients who have a family history of HCC, they need to be under surveillance even if they are non-cirrhotic. And the APASL, in addition, includes that Africans above 20 years of age, even if they are non-cirrhotic, they should undergo surveillance. For hepatitis C with F3 fibrosis, how we detect this fibrosis is again a matter of debate because fibroscan is not a foolproof diagnosis. The recommendations are weak. Similarly, if there is fibrosis of any etiology, the recommendations are weak. But if it is an NFLD with F3 fibrosis, the APASL feels these are high-risk patients and should be put under surveillance. So if we talk about the controversial group remains the non-cirrhotic Hep B, the F3 fibrosis Hep C, and NAFLD with fibrosis. So most of the guidelines have a divided view, but non-cirrhotic Hep B, if they are in high risk, for example, the ASLD believes if there's a family history of cancer or smoking or concomitant alcohol use, we should be screening these patients. For F3 hepatitis C, we do not know when there is a transition from fibrosis to cirrhosis. So it recommends surveillance for patients if we have undergone a biopsy and there is a bridging fibrosis. Similarly, in NAFLD patients, 50% of NASH HCCs occur in non-cirrhotic, but it feels that we need to have a risk identification model so that we can do surveillance of patients with NASH irrespective of the level of fibrosis. So coming to how do we do surveillance, the EASL guideline believes that 6 monthly ultrasound is sufficient. The ASLD says it's 6 monthly ultrasound plus minus alpha-fetoprotein. They removed alpha-fetoprotein in between, but got it back. The APASL says it's a 6 monthly ultrasound and an alpha-fetoprotein. Ultrasound and alpha-fetoprotein are possibly complementary to each other. So I come one by one. What happens if we do a surveillance based on only an ultrasound? The false positivities are more with an ultrasound than with an alpha-fetoprotein. Why is it? Because in ultrasound, when we do an ultrasound examination is considered to be negative if there is no focal abnormalities or we have definitely benign lesions like cyst. It is considered non-diagnostic if the lesions are below 1 centimeter and that doesn't look like benign. It is considered positive if we have a lesion of more than 1 centimeter. But we should remember that 20% of the ultrasound that we do in the liver patients are considered as inadequate for surveillance because of either poor window or the poor visualization. A meta-analysis of 17 studies showed that surveillance ultrasound detected majority of HCC tumors before they presented clinically with a sensitivity of 94% and a specificity of 94% also. However, if we talk about early HCC, the sensitivity drops down to 63%. However, why we are still using ultrasound as a surveillance tool? Because it's easy to use, it's non-invasive, good acceptance by the patient, cost-effective, and it detects other complications like portal vein thrombosis. Disadvantage, it may be missing a lot of isoechoic lesions. It depends on the expertise of the operator as well as the quality of machine. And sometimes it is difficult to identify the lesions in patients with cirrhosis. Coming to alpha-fetoprotein as a surveillance biomarker. So it is considered the ideal serological marker for detecting HCC. Actually, alpha-fetoprotein is more of a diagnostic tool rather than a surveillance tool. The basis of the suboptimal performance, why we don't consider it as a surveillance tool, is that the alpha-feto level can be very much fluctuating in patients with hepatitis B and C during the course of the disease. And only a small percent, around 10 to 20% of patients in early stage of HCC present with raised alpha-fetoprotein. If we take an alpha-fetoprotein cutoff of more than 20, the sensitivity is 60% and the specificity is 90%. So a longitudinal change in alpha-fetoprotein may be more sensitive and specific. But the moment we take a higher cutoff of alpha-fetoprotein like 200, the specificity increases, but the sensitivity falls to 20%. So here it is, between 20 to 100, sensitivity is 61% and 86%. If it is 200, the sensitivity slowly drops to 49, the specificity increases to 98. If we take alpha-fetoprotein cutoff of 400, the sensitivity is around 32% and the specificity, however, increases to 99%. So when ultrasound is added to alpha-fetoprotein for surveillance, it can detect an additional 6 to 8% of patients, but again, it will have a 7.5% of false positive rate. So this might lead to an 80% increase in cost for each small HCC diagnosed. So alpha-fetoprotein only used for surveillance has a false positive rate of 5%. Ultrasound used only as a surveillance has a false positive rate of 2.9%. Therefore, alpha-fetoprotein is still considered as an inadequate screening test for HCC when used alone without the presence of an ultrasound. Now there are some other that it will help us in surveillance. People have tried alpha-fetoprotein L3 fraction. It is more specific, but very less sensitive. So there has been a proposed diagnostic model, which is called the Gallant model, which includes alpha-fetoprotein L3 fraction, DCP, age, and gender. And it says that for HCC, the sensitivity is around 89%, specificity is around 86%. But if you see for early HCC also, the sensitivity is better than using alpha-fetoprotein alone, around 82%, and a specificity of 86%. People have tried investigational tools like a panel of microRNA, but these are not yet recommended outside of clinical studies. So why not use a CT or an MRI as a surveillance tool? Many people tell us that let us get a CT done in the first detection of the cirrhosis of liver. So as of now, there is no data to support the use of a CT or a dynamic MRI for surveillance. Against CT, the thing is of repeated radiation exposure, and the MRI is the cost. However, if the patient is on a transplant waiting list, CT and MRI can be used as an alternative because we need the CT for volumetric assessment and other findings. Also, people who are obese and where the ultrasonologist feels that there is a chest wall deformity or a significant amount of intestinal gaseous distension, which prevents us from getting a proper visualization, those are the cases where we need to do a CT or an MRI as a surveillance tool. So there has been a study comparing MRI versus ultrasound on 407 patients of cirrhosis, where this was used for surveillance. Among these 407, 43 patients developed HCC. 1 was detected by ultrasound, and 26 by MRI, 11 by both, and surprisingly, 5 were missed by both. What is the point against MRI is that it has a lower false positivity rate of around 2.6% when compared to ultrasound, but this needs to be validated in larger studies before we can push it to a guideline for screening of HCC. So how frequently do we do surveillance? So the ideal interval depends on what is the tumor doubling time of HCC and the tumor incidence in the target population. So most guidelines believe that the tumor doubling time is around 6 months. So they recommend 6 months as the interval at which we do HCC screening. Because the tumor incidence is very high in Japanese population, they feel that 3 months interval is what is to be done. And most of the Japanese guideline says we should do the screening at 3 months. There has been randomized study between 3 versus 6 months. They failed to detect any difference. However, when studies have been seen between 6 and 12 months, there has been definitely in favor of 6 months, which can detect a sensitivity of around 70%, whereas 12 months is only 50%. What is more important is what the previous speaker has also told, is the recall policy. So if we have a nodule of less than 1 centimeter, which we are not sure, a close follow-up may be every 4 months for 1 year and 6 months thereafter, as suggested by the EASL guideline, or even a closer follow-up at 3 months, as suggested by the ASLD guideline, is required. Any nodules more than 1 centimeter will warrant further investigations when detected by an ultrasound. Now, this is something new which is coming up. Till now, we have been doing as a one-size-fits-all policy. Now there has been a role of precision HCC screening, where we try to find out some baseline HCC predictors, whether these patients have a history of smoking, alcohol, family history, and we can use one of the HCC risk calculators. And based on this, we can classify them as high risk, medium risk, low risk, and very low risk. And then we decide whether the very low risk we may avoid screening. And then we may have different screening strategies, like strategy 1, 2, and 3, based on which category they fall into. So, for example, this is just a suggestion that suppose low risk patient may not go screening, very low will not go screening. Low risk patient may undergo a test with biomarkers or a panel of biomarkers. The medium risk may need an ultrasound plus biomarkers, and high risk we can do what is called an abbreviated MRI to use and detect HCC. It will cut down the cost and the screening time. So what are the novel biomarkers that have been developed? So we already have the Fujifilm WECO panel, which is a combination of AFP, AFP-L3, and DCP. And then we have the Gallard model, which I've already shown. The future is possibly roaming around liquid biopsy. These are not yet commercially available, which can detect the genetic and the epigenetic methylation changes. So there is a product under development, which is the OncoGuard liquid biopsy, and the Helio, which takes into consideration the circulating tumor DNA, and also takes the Fuji WACO model with alpha-fetoprotein L3, and DCP. So we should be also trying, as I said, for novel screening tests like an abbreviated MRI, where you take only the T1 axial dynamic phases. And studies have shown that it is a similar sensitivity and specificity to a normal MRI. It is considered to be safe, non-invasive, and maybe half the cost of a normal MRI, and that would lead to cost effectiveness. So in future, we will possibly be shifting from a normal screening model to a screening model where it is based on risk, and as the risk increases, the effectiveness of the surveillance program will increase, and it will be cost effective. As of now, in our center, we are still following the guidelines of using an ultrasound and an alpha-fetoprotein every 6 monthly. But any lesion that we find which is suspicious of malignancy, any lesions more than 1 centimeter, we definitely go for a triphasic MR, or if the patients have claustrophobia, we prefer a CT. And if lesions are less than 1 centimeter, we have a recall policy of calling them early. And if the lesions are more than 1 centimeter, we consider it as HCC unless until proven otherwise. So with this, I would like to end my discussion for today, and would be happy to take any questions, I think, in the end with the panel discussion. Thank you so much.
It was a wonderful presentation. Now we shall move to the third talk by Dr. Anand Kulkarni sir. Current treatment and challenges in HCC management. Dr. Anand Kulkarni sir is a senior consultant hepatology and liver transplantation surgeon, and from AIG Hospital.
My slides are visible, right? Hello?
Yes, sir.
Yeah, and thank you. Thanks, Rosh, for organizing this, and it's an excellent meeting. Actually, it was, in fact, engaging for me to learn about how to surveillance these patients, how to diagnose, put LIRATs, and all those things. So now I will be touching upon current treatment options and challenges in the HCC management. I'll be talking about the options which are available. We have multiple options now. And say I'll just on touching upon the RESIST and BCLC staging. Basically the latest BCLC staging. I'll be reading about that, trying to explain what is the latest BCLC they say now, and some data on the current treatment options, which is already there outside in the academic world, and the challenges we face now. These are the options which we have already. We have sorafenib, which has been started almost a decade, more than a decade back. Then came the lenvatinib, cabozantinib, regorafenib, pembrolizumab, nivolumab, durvalumab, and tremelimumab has also been added in this, the latest BCLC staging, although the Himalaya trial is still to be validated. And atezolizumab is now the actually first-line recommended drugs. This is for systemic therapy. From radiology side, we have trace transarterial chemoablation, transarterial radioablation, microwave ablation, and radiofrequency ablation. From the surgical side, we have resection and liver transplant. All in all, the best curative therapy always remains the liver transplant. There is no doubt in that. We just remove the root cause of the disease if the patient is deemed okay for to undergo a transplant. This is the RESIST criteria. While just the RESIST criteria is partly currently there is one second. RESIST criteria, RESIST 1.1, modified RESIST and the EASL one. The modified RESIST and RESIST 1.1, basically complete response is disappearance of all the measurable lesions is complete is RESIST. Disappearance of all the enhancement is MRESIST modified RESIST. And partial response is more than 30% decrease in the sum of greatest one-dimensional diameters versus baseline sum of diameters of the target measurable lesions. Similarly, in MRESIST, there is a 30% decrease in the sum of greatest one-dimensional diameter of lesion of enhancing component versus the baseline component. Stable disease, any case that does not qualify either for partial response or a progressive disease is stable. Progressive is 20% increase in the sum of the diameters versus the smallest sum of diameters of the target measurable lesions. In MRESIST, there is increase in the viable lesions by more than 20%. These are already the present staging systems which are out there. A TNM staging system, the Okuda, CLIP, BCLC, Japanese, QP, and French models. Each of them have variable factors. Commonly worldwide accepted and most often used by the hepatologist is BCLC staging, which I'll be discussing in the next slides. This was the initial BCLC staging. It was quite simple. It had only, just Dr. Mithun was saying that it had a blanket rule. Stage A directly have two options, stage 0, stage A, B, C, and D. The stages have been kept same, but there are some certain changes which I'll be highlighting in the next slides. Before going to that, the INASL had published its own modified BCLC staging, which had already had this candidate over there. If the patient is suitable for transplant, he can as well undergo transplant in the early stage. This was already published in January 2020 as a modified BCLC staging. Now and also the INASL staging had stage D, which had two stages. There is stage D1 and D2. D1 is tumor within the transplant criteria and a good performance status. The patient can undergo transplantation. Stage D2 is patient who has tumor beyond the transplant criteria and performance status more than 2, where we offer best supportive care. These are certain changes made by the INASL. However, transplantation criteria is actually different to each institute. Each one has their own guidelines which they follow, or the expanded criteria is different for each of them. Not everyone follows the same criteria, and it's very difficult to say that the patient is within the transplant criteria or not. It depends on the institute. This is the latest BCLC staging. I will be briefly discussing about this. Basically, what they say here is the prognosis of the patient depends upon these factors defined by the alpha fetoprotein. They say more than 1,000 is a poor prognostic factor, ALB score, Child-Pugh score, MELD. Presence of variceal bleed in a patient of HCC is also a poor prognostic indicator, though they have not mentioned over here. In the text, they have mentioned that the presence of bleed might also be a poor prognostic factor, but this might not harm the treatment of the patients, and the patient's treatment is based upon the stage of the disease. So we have the same stages, 0, A, B, C, and D. Very early stage is stage 0. There is single lesion of less than 2 centimeters and the preserved liver function, a good performance status. The candidate can undergo transplant and portal pressure and bilirubin. Portal pressure more than 10 or bilirubin more than 2, and the patient has no contraindications, he can directly go ahead with transplant, even if the lesion is single lesion. Or the patient is not a candidate for, they are not willing, or if there are any hurdles for transplant, then the patient can also undergo ablation. Or if the patient has a good suitable margin, can either undergo ablation or a resection. Meanwhile, they also recommend in here that the patient, after undergoing resection, if you find a tumor which there is microsatellite lesions on the resected part, or there is any microvascular invasion, then it predicts that the patient might develop recurrence, and it is better to offer transplant for these patients. In stage A, we have single lesion of any size or 3 nodules less than 3 centimeters, which is nothing but the Milans. The preserved liver function, the performance status, a good performance status. The patient has single lesion and elevated portal pressures more than 10 mmHg. Though they say that the 10 mmHg is not a validated cutoff, but they have mentioned it 10 mmHg is, as of now, is the recommended cutoff. But similarly, recently the Bavano says that for NASH patients, the portal pressure HVPG may not correlate with the actual decompensation. 10 may not be the appropriate cutoff for them, and further studies are still required for that. The single lesion, elevated portal pressures, high bilirubin, there are no contraindications. Again, you transplant the patient. A single lesion with normal bilirubin and normal pressures, you undergo either resection. And if the patient has less than 3 nodules, less than 3 centimeters, there is no contraindication for transplant. Best is to offer a transplant. The patient has 3 nodules less than 3 centimeters and there are certain contraindications, then you offer ablation. Radiofrequency or a microwave ablation depends upon the center availability and the location of the lesion as well. And survival in these patients is more than 5 years. The intermediate stage, we have multinodular, that is, which doesn't fit over here, is nothing but the intermediate stage. In this, they are again classified divided into 3 types, 3 stages. B, the extended liver transplant criteria. This, as I said before, is dependent on the individual centers. Nobody has uniform criteria as well. After the Milans, though, even though the BCLC says that if there is downstaging to be done, it has to be downstage to within Milans. That is, Milans is the definitive criteria. But if the centers have their own extended liver transplant criteria and the size is okay for them, and alpha fetoprotein is less than 2000, they have less than 1000, then you can offer transplant for those patients. Or on the other hand, the patient has well-defined nodules and preserved portal flow, but no, these nodules cannot, they say they are not within your extended liver transplant criteria, then you offer TACE to them. It is a preserved portal flow. That is, the portal vein is patent. There is no portal vein invasion. There is diffuse infiltrative lesion, bilobar extensive involvement. You cannot offer either TACE or transplant. It is better to take them for systemic treatment. For patients who are in B, intermediate, early stages, transplant criteria, probably the survival is better. So for those who undergo TACE, the survival is around 2.5 years, and the diffuse extensive involvement, even without a portal vein involvement, the survival is only around 2 years. Then we come to the stage C, that is similar to the previous BCLC staging, that is portal invasion or the presence of extrahepatic spread with a poor performance, with a preserved liver function, and performance status of 1 to 2, we offer systemic treatment. What are the systemic treatments? I'll be talking in the next slides. That survival is again more than 2 years. And terminal stage D, any patient, and what they have specifically maintained everywhere, that the patient of stage A according to HCC, but if he has any end-stage liver function or child C status, or the patient has other comorbidities which preclude the offering a transplant, then this directly migrate into stage D, where the only treatment is best supportive care. The newer one which they have added here is this one, clinical decision making, and TSM. They have named this as TSM, treatment stage migration. It primes lower priority options due to non-liver related clinical profile. Basically, it's a multidisciplinary team or an individual-based therapy in each of these. What they here note is basically if the patient is not suitable for ablation or resection, if the lesion is not suitable for any reasons, you can offer TACE. They have also mentioned that radioemulsion, transarterial radioemulsion is also suitable for these lesions, for lesions less than 8 centimeters. I don't remember the trial name, but in the trial, they had a median size of 2.5 centimeters, the maximum size up to 8.1. Hence, they have commented upon TARE can be offered for a patient who has single lesion less than 8 centimeters. Then if the patient is not feasible even for this stage, then you will go for the systemic therapy. For stage B, the patient has undergone TACE and he has successfully downstage within the Milans, preferably within Milans, to offer transplant again. For a patient who has TACE, who cannot be offered any other, who is not feasible for TACE as well, so again go for systemic chemotherapy. As per the NEJM IM trial, which will be discussed again by Dr. Bharat in the next few hours, atezolizumab is the first line therapy that they have recommended, that is the best therapy. And durvalumab and tremelimumab from the Himalaya trial, only single trial, but they say that this might come up to a first-line therapy in later years. Hence, they have just mentioned it, but they are not given a valid recommendation for that. If not feasible, sorafenib or lenvatinib. The second-line drugs, again, we have sorafenib. If the patient is sorafenib tolerant and the disease is progressing, we have regorafenib. Cabozantinib, irrespective of the tolerance to the sorafenib, and ramucirumab, the EFP is more than 400, you have for ramucirumab. And if the patient has, even despite there is progression, after this, they say that cabozantinib is a good third-line drug. The data and these will be just be touching upon in the later slides. If the patient has still progression after these drugs, then you enroll them from the clinical trials. If none of them are feasible, then you offer a best supportive care. This is the latest BCLC staging. They have also updated BCLC. One more thing they have added, which is nothing but BCLC upon progression, BCLC-P, which is they termed it as BCLC-P. There, the patient who has a child CTP-A performance status, good performance status, there is radiological progression after treatment. The patient was in BCLC-B or C. If the patient has progression, that is growth of more than 20% of the existing nodules or a new intrahepatic lesion. From BCLC-B, he is within BCLC-B, then we say BCLC-P, that is BCLC progression within B. The patient is within C, then we say BCLC progression within C1. But if the patient has developed a new extrahepatic lesions or new vascular invasions, then we directly stage them to BCLC progression C2. This is a new addition to the new BCLC now. So basically what we said now, we had to operation, surgery is the best therapy. There is no doubt transplant is the best therapy to be offered. 30 to 35% of the waitlisted transplants in Europe are HCC usually. And expected 5-year survival rate for patients meeting Milans is 65 to 80%. Liver resections have similar outcomes for patients with small HCC who do not have a clinically significant portal hypertension. These are all the available criteria: Milans, UCSF, up to 7 total tumor volume plus alpha-fetoprotein, AFP French model, Hangzhou model, Seoul model, and Metro ticket, Asan model. Milan is the one which is validated and probably the best to date. Though there are in center-based criteria, I do not want to comment on this. Basically, Milans is a single lesion less than 5 centimeters or 3 lesions up to each less than 3 centimeters with no extrahepatic manifestations or no evidence of any macrovascular invasion. UCSF, on the other hand, is single nodule less than 6.6 or 2 to 3 nodules less than 4.5 centimeters. Total diameter of less than 8 centimeters. So on, we have many models over here, and each center has their own models basically. But alpha-fetoprotein more than 1,000, they say it is the patient should not be offered transplant for these patients. Again, as I said, these are all the criteria for liver transplantation. This was the landmark trial, landmark study, 48 patients with cirrhosis with hepatocellular carcinoma, tumor less than 5 centimeters or less with a single lesion, or no more than 3 nodules or each less than 3 centimeters were evaluated, who underwent transplant. The overall mortality rate was 17%. After 4 years, the actual survival rate was 75% and the rate of recurrence-free survival was 83%. So single lesion, less than 5 centimeters, 2 to 3 less than 3 centimeters, and absence of vascular invasion and extrahepatic spread is Milans. How does alpha-fetoprotein affect our treatment modality? Basically, there have been 2 studies. There have been several studies actually. One about the 300 cutoff, the other about the 1,000 cutoff. This was the study which was published in the American Journal of Transplant in almost a decade back. 153 patients with cirrhosis and hepatocellular carcinoma. There is progression of alpha-fetoprotein by more than 15 nanograms per ml per month on the waiting list. Yes, the survival is probably only dismal. The alpha-fetoprotein, these patients have only post-LT recurrence of almost 34%. The patient has alpha-fetoprotein less, not increasing, and alpha-fetoprotein more than 300 nanograms. Then the post-LT recurrence is 14%. So rate of progression is also important, and the value of alpha-fetoprotein is as well important. Then alpha-fetoprotein less than, these are the studies which say that more than 1,000 is an absolute contraindication for transplant. They have high chance of recurrence. Both these studies published in the liver transplant and gastro say that patients who have more than 1,000 have dismal prognosis. Post-transplant, patients applying AFP within more than 1,000 to patients within Milan criteria results in exclusion of 5% and 20% reduction in the post-LC HCC recurrence. So how to predict, this is, I just want to touch upon this important study, how to predict the recurrence of HCC after liver transplant. This is a retreat study. Basically, it had alpha-fetoprotein at liver transplant, 21 to 99 is 1 point, 100 to 1,000 is 2, more than 1,000 is 3 points. With microvascular invasion, presence of is given 2 points, and the largest tumor size plus number of viable lesions. Less than 5 is 1, 5 to 10 is 2, and more than 10 is 3. Based on this, what they have is 0, 1, 2, 3, 4, and more than 5 scores. The risk of recurrence increases with the scoring. 0 is less, up to 4 we have almost nearly less than 10%, and once the score reaches above, more than or above 5, the recurrence is very high. The one after at 1 year LT as well as the 5 years liver transplant. Locoregional therapies. There are several locoregional therapies which can be offered to these patients. Basically, most of them are used as a bridge. Dropout rate of HCC patients on waitlist is around 20%, and these locoregional therapies can act as a bridge by preventing tumor progression and probably reducing the biological activity. There are possible oncologic benefits beyond the bridge to transplant. To consider bridging therapy, there should be a wait list of at least 6 months. This is also holds true in the recent EBCLC guidelines as well. So expanded criteria, if there is, if you have expanded criteria, then the patient might go for transplant. If not, downstage the patient to Milan's and then take him for transplant. So what can be used for bridge? SBRT, TACE, or RFA. Currently, the BCLC does not recommend SBRT. They only have TARE, TACE, and RFA. BCLC somehow is skeptical to include SBRT, and they say that the trials are limited and cannot be benefited. In this study, which was published in Journal of Hepatology, they said that all of them have similar efficacy. The dropout rate was similar. The patients have actual survival from time of listing was similar in all the patients. So there is no much difference whatever modality you use based on the size or the location. Probably it depends on the individual preference and the location of the size. But obviously, all of them had a similar outcomes in these patients. Coming to the drugs which are available, I will be touching upon the oral drugs and not much upon the bevacizumab and rituximab. The first trial, which was published in NEJM, was in 2008, the SHARP study, in which sorafenib was shown to have a significant median overall survival of 10.7 months versus 7.9 months. This trial has been cited more than 10,000 times from NEJM. In the Asia Pacific region, they showed that the median overall survival is 6.5 months versus 4.2 months. Now sorafenib is slowly phasing out. I don't know how many of them are using, but we most often prefer, if at all, if the patient requires oral therapy, we would go out with lenvatinib. So lenvatinib has approved indications: thyroid cell carcinoma, renal cell thyroid, hepatocellular carcinoma, and endometrial CA. This is the reflex study published in Lancet, where patients were given drugs based on their body weight, 8 mg for less than 60 kilos, 12 mg for more than 60 kilos, and versus compared against sorafenib. The primary endpoint was overall survival and progression-free survival. The median alpha-fetoprotein was 133 versus in 71 sorafenib group. Overall survival, there was significant decrease in there was hazard ratio. It was non-inferiority study basically. So the progression-free survival was significantly better, 7.4 months versus 3.74 months. Time to progression was 9 months versus 3.7 months. And overall response rate was better in these patients compared to sorafenib group. Lenvatinib has advantages. It can also inhibit potent inhibitor of FGFR4, though we recently had a discussion that probably that's the only reason that they say that it is probably more effective. Lower dose is required for anti-angiogenesis effect. Lenvatinib has a low possibility of drug-drug interactions and less incidence of hand-foot-mouth syndrome. But a caution of hypertension. Hypertension is a little higher with this in this drug. It is rapidly absorbed, extensively metabolized, and excreted in the urine. But a single dose of 24 mg reaches a peak plasma concentration within 1.5 hours. The terminal half-life is around 24 hours. Hypertension is the common adverse event: hypertension, fatigue, diarrhea. Monitor for hypertension. Hypertension has to be treated. It occurs in around 45% of the patient. That is around nearly alternate patient has developed hypertension. Control the blood pressure prior to initiation of the drug. Monitor the blood pressure every week, and then every 2 weeks after the first 2 months, and then at last monthly thereafter during the treatment. Withhold and resume at reduced dose when hypertension is controlled or permanently discontinued based on the severity. There are some risks of hepatotoxicity. Around 2 to 3% can also develop hepatotoxicity. Monitor liver functions every 2 weeks for the first 2 months and at least monthly thereafter during the treatment. So what they say here, the basic advantage of lenvatinib is having FGFR4 inhibition. It has significant FGFR1 inhibition, FGFR1 inhibition more than FGFR4 inhibition in these drugs. It is the only tyrosine kinase inhibitor which has activity against FXR pathway. So this is our study which was published recently as a small letter in one of the journals, GastroHep. It was the first Indian experience, the real world experience. We had around 63 patients who were treated with lenvatinib from the Department of Hepatology. The most common cause was probably NASH. Viral marker, that is HBV and HCV were 31, and NASH was around 28 patients. The maximum diameter was around 6.7 centimeters, and baseline alpha-fetoprotein obviously above 1,000 in these patients. Portal invasion was noted around 28%. Child pug A were 28 and 35 with B. BCLC B were 34 and C were 39. There was extrahepatic met noted around 9 patients. Some of them had received prior therapies such as TACE, most often was noted in around 20% of the patients, followed by RFA in around 12% of the patients. 62% of the patients were initiated on 8 mg dose and the rest on 12 mg. However, there are a significant number of patients who developed adverse event, that is almost 56%. The median tolerated dose in our cohort was 8 mg. So after this, we are now switched to start only with 8 mg. If the patient even does not tolerate 8 mg, we change them to 4 mg. The median duration was 4.5 months. Noted hypertension, nausea, and diarrhea, which are commonly noted in other patients, other studies as well. One of the patients as well developed a tumor rupture. Treatment had to be discontinued around 20% of the patients, and some of them were treated with regorafenib, though there was progression of the disease. On Kaplan-Meier analysis, we found that the median progression-free survival is 5 months, and median overall survival was 10.5 months, and 52 patients were evaluated with my mRECIST. None of the patients could achieve complete response. This is the major drawback of all these oral drugs, which might not be true with immunotherapy drugs. 27% achieved partial response and 44% had a stable disease. Nearly 30% had progression of the disease. The next drug is regorafenib. It is basically the resource trial. Regorafenib should be given in these patients who are tolerant to sorafenib but who are progressing on sorafenib. If the patient is intolerant to sorafenib, he cannot tolerate regorafenib as well. Dosing is 160 mg for 3 weeks, followed by a week's gap, and then restart regorafenib at 160 mg. It has a good significant benefit with median overall survival as well as median progression-free survival. The next drug, there is similar to as I said previously, the number of patients who developed complete response is hardly 1%, only 2 patients. And most of them had a stable disease compared to those who in placebo could not have a stable disease. So the adverse events noted were hand, foot, mouth syndrome, diarrhea, and fatigue and hypertension, which is common to all these all these drugs. Next is Celestial trial, that is cabozantinib for previously treated HCC. This you can give even if the patient is intolerant to sorafenib. It is a multi-targeted tyrosine kinase inhibitor at a dose of 60 mg per day. The overall survival is much better with cabozantinib, and median progression-free survival is as well better with cabozantinib compared to placebo. The overall, as I said before, the complete response is 0 in these patients. Partial response, it is usually a stable disease which can be achieved with these drugs. As again, the side effects are most often diarrhea, loss of appetite, hand, foot, mouth syndrome, fatigue, and nausea. The next drug is ramucirumab, which is also can be given for patients who are progressing on sorafenib and or intolerant to sorafenib. But in this trial, they included a patient who has alpha-fetoprotein more than 400 nanograms and child weight. It was given at 8 mg per kg intravenous every second week. They noted improvement in the median overall survival as well as the progression-free survival. Currently, EASL recommends that lenvatinib is non-inferior to sorafenib and is also recommended as the first-line therapy in patients with well-preserved liver functions and who are, if the patient has still progression, then you can change it to the second-line drugs, which are nothing but regorafenib in the patient who is tolerating and progressing on sorafenib, or cabozantinib and ramucirumab who has a patient on who is progressing on sorafenib or intolerant to sorafenib. We all know that the checkmate, that is nivolumab, was actually a failure. And the p-value could not reach a significance of less than 0.05. It has a p-value of 0.07 and hence probably not recommended in the current guidelines. Coming to a few of the loco-regional therapies, which I'll be touching upon, is basically contraindication. Most of the students will not be knowing that what are the contraindication for TACE. Related to liver cirrhosis, a patient who has decompensated cirrhosis or presence of jaundice more than 2 or a clinical ascites or refractory ascites, HE, hepatocellular syndrome, impaired portal vein blood flow, that is portal vein thrombosis, are contraindications for TACE. HCC, that is related to HCC, extensive tumor involving the entirety of both lobes or tumoral portal vein thrombosis, and technical contraindication if the patient has creatinine more than 2 milligrams because of the use of contrast. Combining TACE with tyrosine kinase inhibitors, there has been no benefit as shown in with sorafenib as well as the brivanib. But however, a recent study which was published in Cancer, TACE was combined with lenvatinib versus TACE plus sorafenib. There they showed that patients, there are around 62 patients, hardly 32, 64 patients, 32 in each group. Participants with previously untreated HCC and PVT were received again TACE plus lenvatinib versus TACE plus sorafenib. After a median follow-up of 16 months, in the lenvatinib group had higher treatment time to progression compared to patients who received sorafenib, and the objective response rate was much better. That is almost double those of who received sorafenib. On multivariate analysis, TACE plus lenvatinib was associated with higher time to progression and compared to versus those who received TACE plus sorafenib. This is the first trial which has shown benefit probably. I am not aware of other trials, there might be, but this I felt is the latest. Radioambulation versus sorafenib, these are a few studies which I could find. Most of them have shown that it is similar recently, but TARE definitely the recent trial which has been published, TARE definitely has better significance role in these patients who have a tumor less than 8 centimeters and have a portal vein thrombosis with a preserved liver function and absence of decompensations. There are certain factors. TACE is commonly used. That's why I put this slide. The patient who has failure is most often seen in patients. You should see that patient has good liver functions, and patient who has if the patient has multiple lesions up to 8 to 10 centimeters, even then you can offer TACE if there is a super selective TACE. And the type of TACE, either depth TACE or the conventional TACE, both have a similar response, but only advantage of depth TACE is the tolerance is better. Treatment
to conclude, sorry to interrupt.
Done. The conclusion, the treatment is there based on the stage of presentation and center individual based. There are 2 terms which have been added, TSM and UTP, untreatable progression and treatment stage migration. TARE is included but not SBRT, and strict surveillance plays a major role, important role in all these patients. And with the availability of new drugs, we have a better prognosis for these patients. It's a multidisciplinary team approach. Thank you. Over to Bharat.
Thank you, sir. That was a wonderful presentation. You have completely covered majority of the topics. Now I would request my colleague, Dr. Bharat Patodia, a consultant medical oncologist at AIG Hospitals, to talk on role of systemic therapy in unresectable HCC.
Yeah. So thank you very much for organizing this event and allowing me to present this particular topic. Since the sorafenib and lenvatinib questions are done and dusted, that sorafenib and lenvatinib is non-inferior, based on the sharp trial which came and the reflect trial. So I will not be discussing those part, but the latest combination which is at present recommended, that is combination of atezo plus bev, which I will be discussing as first line in unresectable HCCs. So Anand sir already covered the TKIs, and a lot of plethora of TKIs available to us in near future. Uh, should I put it in the full
Yes,
screen
sir.
or?
Yes, sir. So you have to go full screen, sir.
Oh, okay, okay. So starting with the global incidence, Dharmesh sir already covered.
That's still not on the full screen mode, sir.
It is on full screen on my side actually.
Sir, you have to reshare and you have to select
Oh,
share the entire screen option. Yeah, sir. Green button, dialog box open. The first option, select the entire screen and then share.
okay.
Yes,
I
sir.
hope it's okay. So the global incidence and mortality has been covered by Dharmesh sir. Liver cancer does present a significant burden in terms of incidence, but more than incidence, I think the mortality is something which is significant compared to other cancers like lung and breast, where there are a lot of treatment options. While in liver, there are not much of treatment options, and any treatment options is welcomed with enthusiasm. So as mortality is considered, it is the third leading cause of global cancer mortality, accounting for 8.3% of cancer death. Now, global incidence, the global incidence is around 8 lakhs per new cases, and 75 of them are in lesser developed region of the world like us. And liver cancer is fifth and ninth most common cancer in male and female. Men have threefold higher risk of developing liver cancer than women. Now, coming to the HCC, HCC is being the most common type of liver cancers. There are other cancers like cholangiocarcinoma, sometimes mixed adenocholangios, angiosarcomas, and hepatoblastoma. So that is not the point of discussion today. These are rare tumors. We will be focusing on the HCC, the classical HCC. So risk factors are the HCC. There are many ways it get damaged, like with viruses, alcohol, NASH, and rarely aflatoxin mushrooms. Whatever the reason the chronic damage happens, it ultimately can lead to a cirrhosis and ultimately into HCCs by acquiring multiple mutations. Now, in Indian scenario, what we have as data is 35 new liver cancers in 2020, ranking the 10th among the all cancers. So not the most common type, but yes, it is the 8th most common cancer, causing the death in nearly 34,000 patients in 2020. And 5-year prevalence rate is 2.8 per lakh, which shows the unmet need it poses to us. So these unmet needs include majority of patients are presented in advanced stage. So I am working in a GI setup, AIG hospital. We see lot of, or I should say the maximum number of SCC all over the India, but majority of our patients are still in the advanced stage. So rarely we find a upfront resectable or HCC which can be downstaged and go to transplant. So SCC 5-year survival is 2.3, which is a grim picture, and current options opted for majority of population is TKIs because of the cost issues, and the lack of better treatment is something which is unmet need too. Now, this slide is already shown by P.N. Rao sir also. 2007, we had sorafenib sharp trial. We showed survival benefit of around a month or so. And till almost a decade, we had nothing to offer except sorafenib. And then came the options of lenvatinib, which came out to be a non-inferior, not exactly a superior option. And then now here atezolizumab, bevacizumab has come as a first-line treatment option to offer actual superiority than sorafenib and exploratory, probably over to lenvatinib also. So what is the rationale behind this combination is HCC has multiple ways it escapes the immunity. For example, there is trafficking of T cells. So spontaneous regression in HCC is known, which suggests that there is an immune system mediated anti-tumor activity. In tumor infiltrating T cells are seen up to 50% of HCC, which shows that these T cells whose function is to kill the tumor cells are not acting. Somewhere they are getting energy. So this is also shown that the tumor which have higher T cells infiltration actually has a better PFS than non-immune hot tumors. So these HCC may evade this immunity cycle by expressing molecules like PDL1, CTLA4, TIM3, and LAG3. Now, against these molecules, what we have is these molecules like atezolizumab, and the rationale behind the bevacizumab addition to this combination is that it enhances the VEGF mediated immunosuppression to promote anti-cancer T cells. So while the bevacizumab normalizes the tumor vasculature, increasing the T cell infiltration, atezolizumab restores the anti-cancer immunity. Also, bevacizumab decreases the activity of immune suppressive cells like T regulatory Treg cells and MDSCs, stromal cells. Okay. Now coming to this study, IM-Brave 150, which was a phase 3 trial where it compared atezo-bev versus sorafenib. So this is a direct comparison with the standard of care, sorafenib, and it was randomized to 2:1 open label. So they were stratified based on the region, Asia, excluding the Japan. ECOG performance should be preserved, and baseline AFP less than 400, more than 400. They included locally advanced or metastatic or unresectable HCCs in which the local ablative therapies could not be given. And the treatment, either atezo-bev or sorafenib, was continued till there is unacceptable toxicity or loss of benefit, and survival follow-up data was evaluated. The high-risk patient included this subgroup, that is, patient with have main portal vein, the bile duct involvement, more than 50% liver occupying tumor, and they were evaluated with RECIST 1.1. There were few secondary endpoints like overall response rate also. Now the baseline, this is 2:1. So atezo-bev had 336, while sorafenib had 165. This is well balanced study if you include the 2:1 distribution, whether it is a region wise, performance score, child work score, BCLC. What is this significant is in atezo-bev arm, they also included BCLC C. Then they had substratified with viral infections, alpha-fetoprotein, and disease burden. What they found as a primary endpoint was, in atezo-bev, the median PFS was 6.8 months, while sorafenib had just 4.3 months. So though numerically, clinically, it is just 2 months difference, but statistically, it becomes a significant HR gain of 0.59 towards atezo-bev. Now, follow-up systemic therapy post this is recently updated analysis suggests that in sorafenib, immunotherapy or even chemotherapy were offered, while in atezo-bev, the tyrosine kinase was offered in the majority post-progression. Now coming to the overall survival. So we found that the PFS benefit is there of around 2 months. Overall survival benefit, we actually found that there is a significant HR gain, 0.58 in atezo-bev, while it was sorafenib in 13 months only. So overall survival is not achieved in case of atezo-bev, while sorafenib we achieved at the end of 6 months. So updated overall survival, which was recently released in August 31, 2020, what they found is median overall survival in atezolizumab is 19.2, while sorafenib is 13.4. This is a significant benefit with compared to standard of care treatment, that is sorafenib. So this gives atezolizumab as a category 1 recommendation as a first line unresectable or metastatic HCCs. This diagram shows in any of the subgroup we take, whether it is performance score, BCLC, viral infection, alpha fetoprotein, the atezolizumab is favored over sorafenib. So except the BCLC stage 2, where sorafenib is slightly benefited, whichever subgroup we take, atezolizumab scores better numerically as well as this forest plot analysis. So what are the response rate? Sorafenib response rate, confirmed overall response rate was just 12, while in atezolizumab it is nearly doubling of the response rate. Out of this, what is specific is there were group of people who actually achieved a complete remission also in atezolizumab group, while 0 patient on sorafenib achieved complete response. As we discussed, majority response was this stable disease in sorafenib, that is TKI subgroup, and the median duration of response is 6.3 in sorafenib, while not achieved in atezolizumab. So updated response as of cutoff of August 31, 2020, and duration of response. Median duration of response was 18 months in atezolizumab, while just 14.9 months in sorafenib. Again, there were subgroup which achieved a CR. This gave more confidence to offer atezolizumab upfront rather than sorafenib. So as far as safety summary, many clinicians have this notion that atezolizumab can sometimes decompensate the residual function. However, this side effect is not reported in clinical trial. So any grade side effect does happen in 98 patients. However, clinically significant grade 3, grade 4 adverse effect happened only in 57 out of 329. That is less than 20% of the patient. The grade 5 adverse effect, that is life-threatening side effects, happened only minority of the patient, of only 2 out of 329. So you can see that treatment associated decompensation, I do not think many clinicians which find it risky to give atezolizumab in borderline high bilirubin because of the disease should worry about grade 5 adverse effects. So adverse effect leading to withdrawal for any component either from disease or treatment related is 16. Dose interruption required in 50 patients, and modification of sorafenib was required in 37. So IM-Brave 150 illustrated some typical differences safety profile between the tyrosine kinase inhibitor and cancer immunotherapy based regimen. So what it suggested is, while sorafenib had a significant grade 3, grade 4 adverse effect, atezolizumab did not have as high as grade 3, grade 4. They did had side effects, like many patients developed the diarrhea as colitis as atezolizumab combination. Some had bevacizumab induced hypertension, but not exactly grade 3, 4 compared to TKI. Now, the rate and grades of bleeding between the IM-Brave 150 were similar between the treatment arm. So many people are even now afraid to offer bevacizumab as treatment option, considering the possibility of gastric varices in patients. Though in this trial they have not included with impending bleeding of varices. So what they found is, whether you consider sorafenib, lenvatinib, or atezolizumab, the all grade bleeding is kind of similar. It is just 4 in lenvatinib, sorafenib it is 4. In IM-Brave study, it was atezolizumab had 6. So IM-Brave 150, sorafenib, atezolizumab both had grade 3, 4 equal. In Reflect also, lenvatinib versus sorafenib had equal. All of them have VEGF inhibitions to certain extent. So bevacizumab causing variceal bleeding is not something to afraid of. Though if there is an impending varices, then we should get it bending or sclerotherapy done. Impending varices should not be included, should not be given bevacizumab without getting addressing them. So bleeding events with systemic therapy were typically low in grade and unrelated to varices. Personally speaking, last 2 years I have been in AIG. I had just one patient who developed variceal bleed post atezolizumab. Probably in that case, they happened to not present to the hospital when the bleed happened. So varices activity was assessed beforehand, offering any of these atezolizumab or sorafenib combination. In atezolizumab, they have these type of epistaxis, esophageal varices, minority 2.4, GI also similar. So hepatitis occurred at similar rates between treatment arms in IM Brave 150 atezolizumab and sorafenib. So hepatitis in atezolizumab, any grade 43, grade 3 4 clinically significant was 21. Similar number was present in any grade of sorafenib, or grade 3, grade 4, 17. So assessment, they also had patient-related outcomes like quality of life, physical activities, and other symptoms like fatigue, pain, appetite loss, which do happen with tyrosine kinase inhibitors. What they found is atezolizumab, the median time to deterioration was longer. So patient overall quality of life was much preserved in atezolizumab versus sorafenib. I had one patient recently evaluated on atezolizumab. So he had received 21 cycles of atezolizumab with absolute preservation of quality of life. He absolutely no hand foot syndrome, no fatigue, nothing. He tolerated atezolizumab very good for 21 cycles. So that is what I want to emphasize on this slide. So quality of life must be considered when choosing a regimen. We cannot cure the patient, but let's not deteriorate the quality of life. Whatever time we are giving, we should give it a better quality. They should be able to enjoy it. So compare atezolizumab or sorafenib. I just covered. Atezolizumab had 13 months time to deterioration, while sorafenib had just 5 months. And whichever side effect we consider, appetite loss, loose motions. So loose motion definitely way less in atezolizumab compared to sorafenib, being a TKI. Fatigue, treatment induced fatigue is less in atezolizumab. Jaundice, decompensation, less in atezolizumab. So here comes the systemic therapy options for HCC. Very simple. We do have sorafenib, lenvatinib as treatment options. However, personally speaking, patient is fit for treatment, no variceal bleeding, finances are not limited. Probably atezolizumab is what we will offer as first line. As a second line, Dr. Anand Kulkarni already covered. Nivo has been chucked off as a treatment option because it did not meet overall survival benefit. Though it was given an accelerated approval on a phase 2 trial, but after the updated overall survival, no benefit, it has been removed. We can offer regorafenib, cabozantinib, ramucirumab as treatment options. There are group who has been offering based on the phase 1 studies Nivo EP combination, but probably at present widespread acceptance of this combination are still awaited. So this is the guideline which we have discussed. So HCC, if it is in child pug A, B, resection, treat, transplant, if they are fitting in the transplant category, we can offer these subgroup who are not transplant eligible or inoperable upfront, loco-regional therapy as TACE, TARE, SBRT sometimes if there are portal vein invasion. Though it is institutionalized practice, and systemic therapies as atezolizumab, len, or sora. Clinical trial, downstage, if achieved and patient become transplant eligible, then probably transplant later point of time. Incidentally, I'll just quote recently a patient got operated a week or 10 days back. The tumor was at present inoperable. A portal vein grossly infiltrated was there, and the tumor size was 14 centimeter. We started atezolizumab as kind of a treatment option. the absolute wonderful response after 3 months, 3 months, 6 cycles, and the tumor reduced to 10 centimeter with portal vein got free, and recently patient got operated, resection done. So probably in future we will have more data of atezolizumab and other combinations offering in this subgroup of patients who are upfront inoperable but get good response and later got operated. So metastatic disease, atezolizumab and similar treatment options, SORA and LEN remains treatment options. Second line treatment do have multiple treatment options like Nivo EP combination. Pembro has been used. So this is for future. I have included two more slides from my side. What are the key ongoing randomized trial? So we can understand if atezolizumab has come all the way to the first line, more combinations are bound to come. So these combinations are under study, like len pembro versus len, which is again phase 3 studies. So TKI plus TKI plus immuno-oncological drug, Himalaya IO combination versus standard of drug, TKI cabozantinib plus atezo versus sorafenib, IO Nivo EP versus SORA or LAN. So all these trials are based on certain phase 1, phase 2 studies like Keynote 524 or Study 22 or Celestial studies, and probably future will tell what more options we can offer to the patient at these type of patients. Now, selected, though my topic is metastatic inoperable, just to mention in adjuvant or neoadjuvant immunotherapy, again, there are a lot of trial, and we were fortunate enough at AIG, we could host this Emerald 2 trial, and recently we could enroll one patient on this trial also. So this atezolizumab combination, which I shared a patient there where we got a good response. This is also under study where they have actually offered atezolizumab in that subgroup of the patient versus active surveillance. So with this, I will conclude my last slide. So combination of atezolizumab has demonstrated efficacy in unresectable SCC in the phase 3 trial named IM Brave 150. It was statistically significant, clinically meaningful in terms of overall survival, PFS benefit over sorafenib. This also reduces the deterioration of patient-related outcome, physical functioning, role functioning, and key symptoms like fatigue and hand-foot syndromes, diarrhea. Positive phase 3 data for atezolizumab highlights the benefit of targeting multiple steps in cancer immunity cycle and has the potential to transfer the current treatment paradigm for first-line unresectable SCCs. We will see more combinations in future. At present, treating SCC is less confusing. When we will have more treatment options, then probably it will get more confusing which one to choose and offer first. With that, I will end my slides. Thank you very much.
Regarding the systemic therapies in HCC. Now, let us move to the panel discussion. I want to invite Dr. Damesh Kapoor sir from Yeshoda Hospitals, Dr. Mithun Sharma sir, Dr. Anand Kulkarni, and Dr. Bharat Patodia, and also PN Rao sir to add his insights. Now, I have my slides uploaded, please. Is anyone uploading my slides? Yeah. Majority of the topics have been previously covered by my previous speakers, elucidated manner. Now it will be a recap of the session which we have already seen. Next slide. Today we will be discussing regarding a hypothetical case. This case has been given by the Roche guys. Okay, we have got a 70-year-old male gentleman. He lives in the UK. He has a HCV related cirrhosis and had a previous history of atrial fibrillation and hypercholesterol. He was diagnosed in HCC in the year 2010 with a 2 centimeter nodule in segment 4. Next slide. Yeah. In 2010, when he was diagnosed with a HCC, he underwent initially 4 sessions, and the disease was under control for 4 years. In later 2015, he had a left, and he achieved CR after the TACE procedure, and the disease was under control for an year. And in 2016, he had a recurrence, and he further, and the disease was under control for 2 years. And in 2019, he has a diffuse signal abnormality in the segments 2, 4, and 6, which as seen in the figure. At this point of time in 2019, he was having a disease which was not amenable but local therapy, and his AFP levels were high, which is 17,000, which is 1754. Next slide. At this point of time, I just want to take I would like to take the opinion from my panelists. What are the options? What are the therapies we would like to consider in an unresectable HCC patient? And what are the comorbidities you would like to look into before proceeding with the therapy? And what is the fitness assessment you would like to do? First, I would start with Dharmesh sir.
I think the story in this patient dates back to almost 7-8 years ago.
Yes, sir.
And of course, the comorbidities that you mentioned, as also the age, would not come in the way, and we will all go with the performance status of the patient. And atrial fibrillation per se or dyslipidemia is not a contraindication to considering somebody for transplant. Having said that, you haven't mentioned the alpha-fetoprotein at the outset, as also at least the imaging is limited whether there was any vascular invasion or not. So the definitive treatment for HCC this size, as has already been alluded to in the management algorithm talk, would be the transplant if this patient is found worthy of transplant by way of pre-transplant evaluation. So that is what one would do. Having said that, you might also want to argue that resection is equally good. In its initial presentation, this patient had disease which was located only to segment 2. And we do not know what the extent of total hypertension and tests of liver function were, but just atrial fibrillation or dyslipidemia would not come in the way of a curative treatment.
Yeah.
Now, what was done for this patient is...
He was 82, no, sir, years?
70 years, they said.
And now it is 2010, he was 70.
Yeah,
no?
so that's what I'm saying. So 8 years ago, when you did not have all these options available, I would definitely have considered this patient for resection. Then if there was any contraindication to surgery, say by way of fitness or cardiopulmonary status evaluation, then I think whatever the treating doctors did was fairly okay, because you did not have too many options at that time. Small lesions less than 3 centimeters, RFA is perfectly justifiable. Of course, this patient kept getting the repeat RFAs. We don't know exactly why that happened, whether there was recurrence radiologically or whether the tumor markers were going up. So all that information is not available to us. And then when they found that this disease had become more expansive, they subjected to TACE, which is again not odd. So I think they probably did what one would have done those many years ago in a non-transplantable patient, except that at times some of us also use adjuvant therapy in the form of TKIs. At that time only probably sorafenib was available. So I think whatever was done in the yesteryears was fairly okay. If this patient was seen now, then obviously the treatment options are far greater, and probably would start somebody with a disease across 2 lobes of the liver in a 70-year-old. We would look for an extra hepatic spread. The treatment options, of course, would be in the form of a systemic therapy. Locoregional therapy still cannot be ruled out, but you would need better imaging to say whether a locoregional therapy would be worthwhile in this situation.
Yeah. Points well taken, sir. Thanks for your insights. And any difference of opinion from either Dr. Mithun sir or Anand sir, or you?
So I agree to what Dr. Dharmesh Kapoor has said. So only thing is that why were there so many recurrences is very surprising. 4 RFA means were they new lesions or the same lesion?
Yeah,
So we don't know about
is
it.
not there, yeah.
Yes. Now, this patient at the evaluation by this hypothetical case, at the time of the presentation, at this point of time, patient was he has no esophageal varices, ascites, or encephalopathy with preserved performance status, and he has been started on atezolizumab plus bev. Is Dr. Bharat around? I don't think
Yes,
so.
I'm here.
Yeah.
In
Do
between,
you do you routinely evaluate for esophageal varices status before you could start him on atezolizumab?
Yes, so Dr. Rajesh, unfortunately, I learned it the hard way. As I said, one of my patient did develop only one patient in last 2 years, but they did develop variceal bleed. So I don't start at atezolizumab till esophageal varices are ruled out, or at least bending is done or sclerotherapy is done, that it is not going to bleed immediately.
Okay, thank you. And this patient had been started on atezolizumab plus atezolizumab and bevacizumab, and 3 cycles of atezolizumab have been completed, and post which he has fairly tolerated well, except for grade 2 fatigue and myalgias. Next slide. Post 4 cycles, CT and MR showed a partial response, and patient had a clinical subject-wise improvement. Fatigue subsided, and in view of the ongoing partial response, patient continued to have a same regimen. He received completed total 9 cycles of 9 months of atezolizumab plus bevacizumab. At this point of time, patient had ongoing new symptoms, and AFP started increasing, and it was a intrahepatic progression. Now I would like to ask Dr. Anand Kulkarni sir, what are the regimen options you would like to consider, or what are the factors that would make you decide once who have progressed on atezolizumab combination?
Most important factor is the patient is on, in Indian settings, we think about performance status and financial status.
True,
Supposing the patient has tolerated the injections well and his performance status is well enough, probably we'll switch over to either tyrosine kinase inhibitors, probably in the form of lenvatinib, which is better option. But it's very difficult for us to convince any patient to receive so long atezolizumab. Bharat, how many cycles you have given in total?
So one patient had 21 cycles, but it is just one out of all of them.
Dharmesh sir, any comments, sir? How many cycles do you routinely give, sir?
You get medicines for free, so it's not a problem. I'm going to create trouble for Roche. I think it all is response dependent, and I think we should choose our patients carefully. We must inform the patients upfront that there are no stopping rules for this treatment unless the patient decompensates or there is objective evidence of tumor progression. It's in my experience, the proof of progression is not very straightforward once you have resorted to IO. It's far more difficult than loco-regional therapy. So that is something to bear in mind. We also don't have much information on how to evaluate LIRAD's TR for this group of patients. So again, that is a work in progress. So it's very difficult to know conclusively just based on imaging. I shared some images of patients who had received IO, the case that I showed, but we've seen variable responses in different patients. So again, I think there is no final word on how LIRAD's TR works out for patients on immune oncologic agents. Just to say, Dr. Rajesh, you said that this patient was switched to lenvatinib. So yes. Is there evidence that lenvatinib should be used as a second line drug?
No, sir.
Yeah, so that's what this case also highlights. We all treat our patients the way we want to treat them.
Yes, because of
So,
maybe logistic reasons.
so did you have any biopsy from this patient? No.
No, sir.
Yeah, because I think the only thing that can lead to a switching and non-response like this is if you are having an immunosuppressive state inside the tumor,
Yes,
or
sir.
if the MSI is high. If the MSI
Okay.
is high, then those are the patients who don't respond, and then lilvertinib can suddenly bring down the alpha fetoprotein after even we give etilobev.
Yeah, I do
Presence
agree.
of beta catenin also, no? Something.
Yeah, beta catenin also, right?
So I think those are the things to be studied at the outset, not at the time when somebody is been on therapy.
Yeah, yeah.
If we had this information right at the outset, then probably those who have
Beginning.
Wnt beta catenin pathway mutations, they don't respond too well. And actually those who have got a high tumor mutational burden or who have got a high microsatellite instability, they tend to respond well. But many of the patients with HCC would not fit that bill. So the incidence of a high tumor mutational burden and MSI is very, very low in HCCs.
Yeah, I do agree with your points. Next slide. So clinicians must balance a broad range of factors in order to reach the treatment decision. As previous speakers also rightly said, it should be a MDT approach. Even from the time of diagnosis, it should be a MDT approach, especially when it comes to a HCC setting. It should include oncologist, hepatology, or a gastroenterologist, pathologist, surgeon, and a very good interventional radiologist, especially when the disease is localized. Apart from these, the most important, not only the disease related or treatment related factors, but also patient preference and the age of the patient, and most importantly, socioeconomic factors, because the majority of these immuno-oncology agents are financially more burden to the patient, and comorbidities also should play a major role, and other factors like tumor factors, like whether is there any extra hepatic spread or major vascular invasion is present or not, what would be the tumor size, meaning whether the patient is a high risk or not, how is the childbirth status score. These all factors should be taken into consideration while moving by not only by at the time of selection of the first line agent, and also at the time of progression. Next slide. Hypothetically, suppose this patient was treated in this way. Suppose if we have got a few of the conditions, like for example, hypothetical situations wherein which to wanted to know if the patient had prior varices or if the patient had a baseline hypertension. I would like to take the comments on of Dr. Bharat Patodia. Suppose if the patient had a baseline hypertension of grade 3, 160, 140, or had a history of baseline varices, how do you treat these patients, and do you change your management or control the comorbidities and go ahead with the same combination?
Yeah, so blood pressure is something which I will not, change my treatment options for. Blood pressure can be well controlled, or recently our center also had refractory blood pressures to control by renal artery ablation. So yeah, the blood pressure is not something for which I can change the theory, but change the treatment options. But probably yes, impending varices are there, or coagulopathy is present. Then probably I will not choose etizobabe upfront.
Okay. And considering his baseline previous history, how would you treat the patient if he has progressed on atezolizumab?
Yeah. So now that cabozantinib is available as easily available, so as cabozantinib is available now, so probably I will offer cabozantinib then lanreotide. But yes, I agree with you. Many off-label use in lanreotide in this setting, even everybody offers it. But yes, it's not.
Why cabozantinib? Why not lanreotide?
So it is cabozantinib is approved as a second-line treatment option. It's a paucity of data that lenvatinib post IO whether to offer it or not. I'm not saying it is not effective. I'm saying it is not being studied. So Just because
Off-label
cabazon
we can use,
is
like you rightly said, many patients are being given this treatment.
yes,
And it's
I
not
agree, sir.
the second line drug.
Next
True,
slide.
sir.
Can we have a next slide? So, how many of the panelists would decide, especially when it comes to selecting a systemic option, like major invasive invasion or extrahepatic spread? Do you think the presence of these factors would help you in determine or reject any of the therapies? We would take opinion one by one. Dr. Damesh, sir.
So I think this is an easy question that you asked. So if somebody has got an extrahepatic spread, then you know that this is a patient for systemic therapy only.
No, sir. My question is, in systemic therapy,
yeah.
would you choose one over the other, one agent over the other, if these factors are present?
Yeah, so again, then if you did have everything available on the table, for example, what was alluded to a little while ago, and at our center we biopsy these lesions and we try to study what the tumor microenvironment looks like. The biopsy has its own pitfalls, and sampling error is one of them. Then it can help you decide. However, if you do not have that, then it will all depend on the patient's ability to spend that amount of money. All said and done, TKI still cost a fraction of what the IO costs. The problem again with TKIs is that at least with lenvatinib, we are all growing in confidence and we've been able to show some objective response rate. But in the sorafenib era, hardly any one of us used to image these patients. So even in the absence of an objective response rate, we were just happy with the quote unquote improved survival, albeit only of 3 months plus. So I think it will all depend on the patient's ability to spend.
Mithun, sir, your takes on the same.
So I will agree to what Dr. Dharmesh Kapoor has said, that if I'm given a choice, money is not a problem. I would definitely go for Etizobev, but explaining to the patient that we might be gaining a 6 months time only, whether we spend this money for that, which lenvatinib would be a more preferable choice if the patient has, it depends on the amount of extrahepatic spread. When you say extrahepatic,
Hello?
just some lymph nodes around. Yeah, am I audible?
Yes, now audible.
Yeah. So if there are only some, we have to define the level of extrahepatic spread. If it's an extensive spread outside, I would still not prefer to go or waste money on immuno, would continue with lenvatinib. But yes, if it's some only periportal lymph nodes, and money is not an issue, I would definitely give him immunotherapy with Etizobev.
Okay. Anand Kulkarni, sir, your take on the same.
This patient will satisfy, I think, BCLCD if he has extrahepatic spread. Portal vein invasion is probably different, and presence of extrahepatic spread would be different. Portal vein invasion we would have for something else, but extrahepatic spread, I would be skeptical in using the Etizobev.
Okay, sir. I just wanted to add one point, because in this Etizobev trial, we do also have 20% of these high-risk patients which are included, because majority of the trials with other agents have excluded the patients of MVI, major vascular invasion or extrahepatic spread. But this is one trial which has upfront included these patients, and almost to a tune of around 20-25%. That is one of the reasons why I just wanted to bring this point on. And
I totally agree that portal vein invasion only per se will not preclude, but presence of extrahepatic spread and extent would probably preclude.
Oh, yeah. Dr. Bharat, your take on this?
Yeah, I'll just add a major vessel involvement. If it is a tumor thrombus, probably it's okay. But if there is a large blunt thrombus also, let's say it is extending up to the right atrium or something, bevacizumab has a possibility of thrombosis also along with the bleeding. So lenvatinib head-to-head bleeding are same, but thrombosis chance are less. So that is my take. If it's a gross blunt thrombosis associated with the tumor thrombosis, then probably I will be a bit cautious to offer.
Oh, okay. Yeah. Next slide. When you see this IMBRAVE 150 efficacy for the patients with MVI and EHS, if you see the patients if they are MVI and EHS are not there, that is around 78 patients at the time of analysis, median OS was not reached. And if the patients who had this MVI and EHS also, around 83 patients were analyzed, which have these patients, the median PFS is 6.5 months with the overall response rate of 27 and median OS of 13.5 months. Whereas if you see the same thing when these high-risk patients, like wherever this MVI and EHS are positive, the median OS is as low as 6 months with sorafenib alone, and if with the median PFS of 2.8 months. And these are the difficult patients, yet we see the doubling of median OS and median PFS and response rates of around 27%, almost 3 times to that of sorafenib, that is 10 months. This point I just wanted to elucidate. Next slide. The same has been seen that IMBRAVE 150 exploratory efficacy and safety results of HCC patients with a main trunk or a contralateral portal vein invasion (VP4) who has been treated with a combination, that is atezolizumab plus bevacizumab versus a sorafenib in a global phase 3 study, has also had the same results, like median OS 7.6 months versus 5.5 in sorafenib arm 5.5. Whereas if you see the overall survival with atezolizumab, it is 21.1 month. Next slide. Would you, one question as rightly pointed out by Dharmesh sir, would you switch this patient from the loco-regional therapy to systemic therapy a bit earlier? Because I don't know why was the therapy given in this way, because it's a hypothetical case which was given to me. Patient had received multiple times loco-regional therapy. So I just wanted to know from the hepatologist perspective, so at what point of the time they will call it a day from the loco-regional therapy and they would refer to their medical oncology colleague? Dr. Dharmesh sir.
So I think the era that you're talking about in those days, even though the evidence for use of sorafenib, and that was, mind you, the only agent available 8-9 years ago, as an adjuvant to a loco-regional therapy, even though there was no evidence in published literature to prove the same, was still a very common practice. And I think all of us, including P.N. Rao sir, would have used sorafenib along with the loco-regional therapy. So I don't think this question would really be valid in that era. In the current era, when you've got all modalities available with you, as Dr. Kulkarni already mentioned, that there is something called a non-response to an LRT, and that should be respected. And if you find that somebody is not having the predicted response to LRT, you should switch to a systemic therapy.
Okay. And any difference of opinion or from either Dr. Mithun sir or Anand Kulkarni sir, any points to add?
I think
See,
what, hello.
Yes, sir. Please continue.
No, I think what Dharmesh has said is correct. You know, in the previous days when sorafenib was, we were using it, randomly we are, actually we were never, almost never assessing the patient. You know, either the patient forgets us or we forget him. Put them on sorafenib and then it goes on, and then repeating the way which we are doing now with the loco-regional therapy and with the experience, you know, has really seen change in our practices. Over.
Sir, your take, Mithun sir and Anand Kulkarni sir. Do you agree with the previous one, or you want any others? Add any new points to the same?
No, because we had no other option at that time. And as far as TACE is concerned, if we are doing repeated sessions of TACE, it would possibly depend on the cumulative dose of doxorubicin that we are using. As far as RFA, I don't think there is a specific number of times at which we can call it a day. It was all a personal choice, I think.
Oh, yeah. Next slide.
You would have considered transplant, sir, at the earlier stages. I don't know why.
Yeah, transplants should have been the first choice anyway. Maybe they didn't have a donor.
So if you see the data from the IMBRAVE 150, the number of mean applications of the TACE, mean number of applications and median number of applications of TACE, if you see, it's approximately around 2.9 to 2.5, and it could range anywhere from 1 to 11 for these patients of atezolizumab arm. Next slide. If you see the baseline demographics of the patients who had a CR with Atezo-Bev, the median age, sex, region, Asian region, rest of the world, ECOG performance status, child book status, irrespective of all these things. And the most important, whether the patient had a EHS and MVI. As we said, these trial had included around 20% of these patients who had a prior EHS and MVI. We do have got best CR rates with Atezo-Bev when compared to sorafenib. Next slide. Next slide. So this has been previously covered. We would, if the patient had a prior varices, we would first send to a gastroenterologist or hepatologist to manage the varices and either medically or surgically or get a banding done. And then we would proceed with this therapy, because we know, even though in the trial, the number of events for the grade 3, grade 4 events of varicose bleeding is same, but in general practice, before going ahead with these kind of agents, we would take a clearance from the gastro or hepatic side from the varices point of view. Does it hold good for even epistaxis? Dr. Bharat, your comments on the same.
Yeah, for grade 1 epistaxis, I think I'll just take as incidental event and I'll not change my treatment options.
Yeah, so I do agree with the same. Even the data says grade 1, I think we can go ahead with. But what they said as per the leaflet also is like, if the patient had a prior varicose bleeding, that should be attended, and post which only should be proceeded to the systemic therapy. Next slide. The same has been told here. The guidelines also recommend for the varices in patients with cirrhosis, and screening is mandatory in this protocol. Patient should have at least undergone an EGD within 6 months of prior to the initiation of therapy, and on screening, if they found any varices, that should be treated as per the standard of care. And once the varices are under control, then they should be proceeded to the Atezo-Bev arm. Next slide. So if you see the number of bleeding events that may occur with the systemic therapy, as told by my previous speaker, Bharat, it is relatively same. When you see either it's a lenvatinib or sorafenib, it's approximately grade 3, grade 4 is 4. And next slide. If you see with the Atezo-Bev and sorafenib arm, it is 6. Next slide. This slide has been already covered. Next slide. Yeah, so this has been already previously said. How would you manage the patient if he had a prior hypertension? Because now that it is not a absolute contraindication or a relative contraindication, but the guidelines you usually say, if the patient had a grade 3 hypertension prior to the onset of therapy, it is better to control the same and then increase, because at a BEV itself also can increase the hypertension. But now this shouldn't be a big problem, because majority of the times, if the patient is found to have a hypertensive, especially grade 3 and above, we would first control the hypertension and next proceed with the treatment. Next slide. Yeah. So fatigue, do we need to change any management? No, I don't think we should change for the fatigue, especially if it is a grade 1 or grade 2. Only symptomatic management would help. Next slide. I'll just try to conclude it in a minute or two, because majority of the points have been already covered. Next slide. This has been already covered, because with Atezo-Bev arm, the quality of life has been preserved and the grade 3, grade 4 events are very less. Next slide.
Dr. Rajesh, if just one comment from my side, the choice of antihypertensive, there is a theoretical discussion over amlodipine being having some concomitant pathway blockage with IO. So probably as my first choice, if not contraindicated, I will offer CCBs as a BP controlling agent. So just a comment.
Yeah, even that is one of the things which have been proposed. And one more thing, what they said, but especially if we had both portal hypertension and systemic hypertension, they would even also, because give beta blockers that would take care of both portal hypertension too, especially if they had a esophageal varices. But if they have got only systemic hypertension, yes, amlo is a good choice, but there's no strong evidence for the same. It is
Not a strong evidence.
yeah. So I would like to end my talk at this by taking the opinion of PN Rao sir. What would be the main thing that would we should educate a patient, especially if the patient we are planning to take them on atezolizumab, and what are the safety precautions we should explain to them? Your closing comments, sir. Is sir around?
He's connected, but I'm not sure.
Okay, then we can take the closing comments from Dharmesh sir. So what is your opinion? Like what should be our expectations as a treating physician, and how should we counsel a patient? Suppose if we are taking him for a atezolizumab on treatment. If you see a new patient whom we are starting tomorrow morning clinic, how should we counsel them?
Right. So I think a few points need to be made right at the outset, even though with increasing experience with these agents, it has been suggested that the category of patients with NASH HCCs, they don't respond as well to IO as the other etiologies. But again, the jury is out. So I would, in a patient who merits an IO, etiology would not play a major role for me. The only important thing is, like I said, and at the expense of repeating myself, we must tell the patient the benefit it offers. We know that there is a proportion of patients, and as you see the Kaplan-Meier curves, they have got a very long tail. So the proportion of patients who respond are likely to have very long-term response to this patient, but it is not as if to say that every patient is going to respond. So with the combination therapy, at best you would see a response rate in about 35 to 40% of patients. The only important thing is the finances that are involved with this treatment, as also the fact that it would need repeated imaging, and we don't have stopping rules. So if someone has been on this therapy and the disease is stable disease, or it is showing objective response rate on serial imaging, this patient would need to continue to be on this therapy. And lastly, because we work in a transplant center, one has to be very mindful of the fact that if someone can be taken to the curative arms of the treatment algorithm, then probably this therapy should be avoided, because the experience with the IO and following that up with transplant is anecdotal. Some centers have tried it, but the results can be very difficult to manage in the post-transplant setting, including graft necrosis. So I think those are the points to be borne in mind when we initiate treatment in a given patient who fits the bill perfectly for IO.
Thank you, sir. It's a wonderful
I think
insights.
it's a good meeting, wonderful meeting, and the main issue is the finances. That is a problem with the patient, as Dharmesh Kapoor has already told, and that's where whether something can be done for that one. Hello.
So yes, these molecules are going to be patent protected for a fair length of time, sir. So we don't have the opportunity of having generic molecules coming to the fore. So I think these agents are going to, that's what I think. Yeah.
Okay.
So they would be patent protected for a fairly long period of time. Maybe somebody from Roche would be able to throw light on them, unless they are charitable, and if the number of volumes are
that's what I meant. That's what I meant indirectly.
I think they should. There is a good enough reason to loosen the purse string, because the volumes are increasing, the experience
That's
is
increasing. That's right.
Our country needs to generate its own data, and these should be the points they should take into consideration. So we are, of course, here not talking of patients being covered under insurance. So patient has to pay from his pocket, and that should be respected.
I'm not sure, sir, if Indian pharmacy develop any of these such molecules, it is going to be any cheaper or not. Probably they will keep the same rates.
Difficult to say. Difficult to say. This Fosovir story tells us something differently. So when Harmony came in the US, the cost was like astronomically high. So I don't think we can just make a sweeping statement like that, because Good thing
I'll
about
take my word back.
yeah, the good thing about Indian pharma is that many people will start doing the same thing. So obviously, there's a great chance of prices coming down.
Yeah.
Sir, your closing comments, and we'll hand over back to the Rosh, sir.
Yeah, I think it's been a very good meeting, very great meeting. And also we learned a lot, and then the mutual discussion and the case has gone on well. And thank you very much. Over.
Thank you, sir.
Thank you so much, sir. So it was a wonderful evening having all of you here, Dr. Dharmesh sir, Bharat sir, Anand sir, Rao sir, Mithun sir, and Dr. Rajesh sir. Thank you so much for joining. Have a nice evening, sir. Good night, sir.
Good night.
Thank you.
Thank you very much. Bye.
Bye-bye.